starting from question number 1 of 34 in cardiac anatomy, right? So we have a 47-year-old previously healthy man is transported to the emergency department after he was involved in high-speed head-on motor vehicle collision. The patient was wearing a seat belt. He didn't hit his head or lost consciousness. However, he has had chest pain and shortness of breath since the incident. On arrival, blood pressure is 160 by 90 mm of Hg and pulse is 115 per minute. Bruising and tenderness are noted over the anterior chest wall. Neck veins are flat. Trachea is central. Breath sounds are symmetric and heart sounds are normal. The abdomen is soft and non-tender. There are no significant extremity injuries, but bilateral femoral pulses are weak compared to the radial pulses. This is important. Note this point. Chest X-ray reveals widened mediastinum. They are pointing toward one point. This is important. While being prepared for surgery, the patient becomes unresponsive, the pulse is no longer detectable, and the cardiac monitor demonstrates sinus tachycardia despite aggressive resuscitation efforts. Okay, the patient dies. Autopsy examination is most likely to reveal an injury involving which of the following areas of the thoracic aorta. So they have given this aorta, ascending aorta, then aortic arch, then descending aorta. So for that, they have given respective options A, B, C, D, and E. Pause it and give the answer. So the correct answer for this is option C. Okay, let us see to the explanation. Okay, so what they're saying, a rapid deceleration during a high-speed motor vehicle collision can lead to blunt aortic injury, that is BAI, due to combination of forces sharing on the aorta. These forces can affect some or all of the layers, intima, media, and adventitia. Okay, most patients exsanguinate, right, rapidly due to full thickness injury that ruptures the adventitia. However, in minority of cases, like 20%, delayed rupture can allow survival until surgical treatment. A high index of suspicion is crucial because symptoms may be non-specific. For example, chest pain, shortness of. Okay, depending on the extent and location of vessel injury, some findings suggest of blunt aortic injury include widened mediastinum. Is I was talking about this thing. This is important. Widened mediastinum, and with that, pulse discrepancy. This is important between the upper and lower extremities, which is similar to the aortic coarctation, right? And with that, intrascapular murmur due to aortic flow impingement. Okay, this is important. So, blunt aortic injury occurs most often in transition zones. This is important. Transition zone is important, right? Between the mobile and fixed portion of the aorta. The most common site of injury is the aortic isthmus, which is location C. This is important, which is tattered by ligamentum arteriosum. Tattered by that means tight by ligamentum arteriosum and is relatively immobile compared to adjacent descending aorta. This is important. And the isthmus is particularly susceptible to blunt aortic injury. This is important due to intrinsic weakness of the aortic wall in this area. So now why not option A and B? Because the aortic root, that was for A, and the ascending aorta near the arch are both transition zones and can be damaged by high speed traumatic injury. However, these areas are affected less often than aortic isthmus. In addition, this patient's circulation is preserved in upper extremities compared to lower extremities, which is more characteristic of an injury distal to the brachiocephalic and left subclavian arteries. This is important. Injury to the proximal aorta is classically associated with complications such as hemopericardium, right? For example, jugular vein distension and coronary artery dissection, for example, ST segment, and the aortic wall disruption, for example, diastolic regurgitation murmur. Why not option D and E? Because the distal thoracic aorta is also susceptible to injury just proximal to the diaphragm due to tearing at the diaphragmatic hiatus. However, this is a less common site for traumatic rupture than the more proximal portion of the aorta, right? This is the same for both option D and E, right? Which are the distal portion. So impacts causing uh, impacts causing the thorax, okay, to rapidly decelerate. For example, high speed motor vehicle collisions can result in blunt aortic injury, especially a transition between relatively mobile and fixed zones. The most common site of injury is the aortic isthmus, which was location C, just distal to the attachment of the ligamentum arteriosum, right? Now, if we look at this, uh, we have over here, this is ligamentum arteriosum, right? Which is located at the isthmus. With that, okay, we have like um, this is ascending aorta, right? Which will branch into right coronary artery with that left coronary artery. Okay, if we go upward, right, um, here is ascending aorta. If we further go, then we have like from the aortic arch, right? This is the aortic arch. We have a brachiocephalic artery. With that, um, if we move, if we move to the left side, right, we have this one which is left common carotid artery, and with that we have left subclavian artery. This one. So we have three branches from the aortic arch. The first one is brachiocephalic artery, with that left common carotid artery, and with that left subclavian artery. And the brachiocephalic artery has further, two branches. Like okay, like we have right subclavian artery. Okay, right subclavian artery. With that we have right carotid artery. Right. So we have right subclavian artery. With that we have right common carotid artery. Okay. Now further, if we come down, we have descending aorta, and in the start like this one, we have ligamentum arteriosum, right? And if we go down, let's say if we go down, then we have descending aorta, right? And one thing which is important, this ligamentum arteriosum has been the derivative of ductus arteriosus. We would talk about that. Okay, moving to the second question. We have a 78-year-old woman is hospitalized due to acute MI. The patient had been having intermittent chest pain for the 3 days and came to the hospital when the pain became unremitting. She has type 2 diabetes mellitus, but her medical follow-up has been poor. On the third day of hospitalization, the patient has sudden onset shortness of breath due to pulmonary edema. Okay, echocardiography confirms severe mitral regurgitation. Okay, severe mitral regurgitation. Okay, she is taken immediately to surgery, which reveals rupture of the posterior medial papillary muscle. Right, this is important. Posterior medial papillary muscle, which would lead to this mitral regurgitation. This patient finding typically suggests compromised blood flow through which of the following coronary arteries. So we have option A, conus branch, then we have option B, diagonal branch, then we have LID, that is left anterior descending artery, then we have obtuse marginal artery, that is the branch of the left anterior descending artery, and then we have posterior descending artery, that is PDA. Pause it and give the answer. So the correct answer for this question is PDA, that is posterior descending artery. Why? Let us see to the example. The mitral wall apparatus consists of mitral wall, uh, annulus, anterior and posterior mitral leaflets, chordae tendineae, which are tethered to the left ventricular wall via the anterolateral and posterior medial papillary muscles. Pathologic processes that disrupt any of these structures can lead to improper alignment of the mitral leaflets, resulting in mitral regurgitation and pulmonary edema. Right? The patient's mitral regurgitation is the result of papillary muscle rupture. A life-threatening mechanical complication typically occurring within 3 to 5 days, right? This is important following acute myocardial infarction. The anterolateral papillary muscle has a dual blood supply from the left anterior descending artery, that is LAD, and the left circumflex arteries, right? So this is for anterolateral papillary muscle. In contrast, posterior medial papillary muscle is applied solely alone by the PDA, that is posterior descending artery, a branch of the right coronary artery, that is right dominant circulation. Our left circumflex artery, that would be called as left dominant circulation, because blood flow to the posterior medial papillary muscle depends on a single artery. It is more likely to become ischemic and rupture following myocardial infarction. Why not option A? Because the conus artery is the early branch of the proximal right coronary artery. It is the branch of right coronary artery, right? It supplies the interior area of the interventricular septum and conus of the pulmonary artery, right? Why not option B? Diagonal arteries branch from the LAD, right? And supply blood to the interolateral walls of the left ventricle. Why not option C? Because the LAD artery supplies the interior two-third of the interventricular septum, interior wall of the left ventricle, and lateral papillary muscle, right? Abrupt occlusion of the LAD rarely results in ischemic rupture of the lateral papillary muscle, right? Is this muscle also receives blood supply from the left circumflex artery. Okay, why not option D? The obtuse, that is left marginal artery, is the branch of the left circumflex artery that supplies the lateral wall of the left ventricle. Okay, so the papillary muscle rupture is a life-threatening complication. Typically occurs within 3 to 5 days after MI, right, and presents with acute mitral regurgitation. This is important, and pulmonary edema. Okay, the posterior medial papillary muscle is supplied solely by PDA, that is posterior descending artery, making it susceptible to ischemic rupture, right? In question number 3, we have a 28-year-old man um, comes to the emergency department with a 3D history of increasing chest tightness, right, and intermittent sharp chest pains. Okay, he also reports mild dyspnea, especially on exertion. The patient has no prior chronic medical conditions but had an upper respiratory illness. Okay, let us see. A week ago, that is a week ago, that resolved without treatment. ECG revealed sinus tachycardia, okay, and low voltage QRS complexes. Remember these things, these are the characteristic of one of the disease. We will talk about that vary in amplitude from beat to beat, right? This is important. Vary in amplitude from beat to beat. Which of the following is most likely chest x-ray finding in this patient, right? So this one is option A. Pause it and see this. Okay, then we have option B. We would talk about all those cases, right? This is option B. Then we have option C. This is also an interesting one. Okay, and we have option D, right? We would talk about this thing. Okay, then we have option E, right? Pause it and give the answer. So the correct answer for this question is option A, right? Why? Let us see to the explanation. So the correct answer for this question is option A. Why? Because this is associated with the effusion, right? As I was saying, this is the case of pericardial effusion. If we look to the normal cardiac silhouette, right, the normal cardiac size would be less than or equal to 50% of transverse chest diameter, right? This thing is important. So if let's say if this is 100, right, this would be the heart size should be less than 50 or equal to 50. Okay, but here if we walk to this case, this one here, this has been increased then 50%. Okay, so the heart has been enlarged and is showing globular silhouette. Okay, so why this is option A? Since this patient, right, with a recent history of upper respiratory infection, was presented with 1 week ago, he's likely developed viral pericarditis, okay, complicated by pericardial effusion, okay. Uh, Viral infection is the most common cause of acute pericarditis, note this point, with Coxsackie virus type A and type B, okay, and ecovirus being the most common organism. But remember this one, okay. Patients with pericardial, uh, okay, patients with pericarditis typically experience chest pain, which may be intermittent, right? Uh, is in this patient, okay, but is often pleuritic and are positional, that is relieved by leaning forward, okay. Is in this patient viral pericarditis can be complicated by pericardial effusion, okay, due to fibrinous or pseudofibrinous pericardial inflammation, okay. Symptoms of pericardial effusion may include a sensation of chest tightness, is in this case, okay, are fullness and dyspnea on exertion, right, due to decreased diastolic ventricular filling that leads to decreased stroke volume, okay. In addition, pericardial effusion often causes the following clinical findings: would present with tachycardia, right, to compensate for decreased ventricular filling, right, low voltage QRS complexes on ECG, and diminished heart sound to auscultation due to pericardial fluid accumulation, increasing the distance between the heart and ECG leads or stethoscope, right, and with that would present with electrical alternance, right. So what are these electrical alternance? These are an ECG electrical alternance on ECG due to swinging motion, right? Due to swinging motion of the heart in the fluid-filled pericardial cavity, causing beat-to-beat variation in the QRS axis. Okay, so patients with pericardial effusion classically have enlarged globular cardiac silicute on chest X-ray, right? Which occurs when progressively pericardial stretching over days to weeks. For example, that is subacute course allows large volumes up to 1 to 2 liter of pericardial fluid to accumulate. Okay, clear lung fields um, are typically seen because the increase in pericardial pressure due to pericardial fluid accumulation affects the lower pressure right-sided heart chambers more than the left-sided heart chambers, right? When right-sided obstruction to the blood flow is greater than left-sided obstruction, pulmonary edema is unlikely to develop. So here they mean to say, let's say I have drawn this heart for you guys. If let's say they are affecting more, more pressure, they are providing more pressure to the right side heart. So there will be less chance of pulmonary edema. They mean to say, let me draw it again for you guys. Let's say if this is heart, right? So if there is less problem on this left side, so the fluid can easily go from left atria to left ventricle, then to the systemic circulation, so that could easy that can be easily go through that. While if there is if let's say if there was more problem on this left side, right, so that fluid in the left ventricle would be accumulated and would go back to the left area, and that would go back and accumulate in the lungs, right. Hyperinflated lungs, this thing is important. Hyperinflated lungs with increased bronchial markings are commonly seen in patients with COPD, right. This is important. Let us see to that. Like normally if we see to this length, this would be not that much high, like it would be just like up to here, but here in this case the diaphragmatic surface has been gone has gone down, right. And also this has been also narrowed, this cardiac silicute. This is not usually just like that, okay. Okay, why not option C? Bilateral patchy infiltrate, right? Infiltrates. Very high layer is greater than peripheral. We would talk about that. That what does it mean? Are concerning for pulmonary edema, right? A normal cardiac silicute may be present is in this X-ray due to an acute cardiac process. If there is acute process, so there will be normal cardiac silicute, right? If there is acute process, that causes acute systolic dysfunction and pulmonary congestion. In contrast, if um, Now this case is important. In contrast, pulmonary edema in the setting of cardiomegaly will be there if there is chronic heart failure. This is important, right? We will talk about that. So they're talking about this one, like normally not that much high perihilar patchy infiltration, right? Perihilar area, but over here this has been increased, right? And there is patchy infiltration, like normally not just like these whitish areas. Okay, absence of right-sided peripheral uh, lung markings, right? Um, Surrounding a small collapsed lung, we would see to that is consistent with large right-sided pneumothorax, right? We would see that picture now. So they're talking about this thing, like normally we do not have things just like that over here. This has been increased. So this is the case of pneumothorax, right? These whitish areas are not normally over here. Okay, let me draw it again for you guys, like now this one till this one, then this one. These are not usually over there. Then we have why not option E, like blunting of the right costophrenic angle. We would talk about that. And loss of diaphragmatic contour are characteristic of pleural effusion, right? So this is the characteristic of pleural effusion. Like over here we can see there is no costophrenic angle, right? Like normally it would be just like over here, but it is been hidden, right? So this is the example of pleural effusion X-ray. Okay, so acute viral pericarditis is commonly complicated by pericardial effusion, right? Classic features of pericardial effusion include tachycardia and ECG findings of low voltage QRS and electrical alternates. These are important characteristics. Chest X-ray classically reveals enlarged cardiac silhouette with clear lungs, right? Okay, continuing from question number 4. We have a 65-year-old man, okay, with a history of coronary artery disease, comes to the physician complaining of progressive exertional shortness of breath, fatigue, and lower extremity swelling. His medical history is significant for a myocardial infarction 5 years ago and an electronic pacemaker implanted 2 years ago. His chest X-ray is shown below. A segment of one of the leads is highlighted. Arrow, okay, you can see this. So they're talking about this thing, right? So they have given various options. Let us see. So the highlighted segment most likely lies within which of the following structures? For example, interior interventricular sulcus, AV groove, that is atrioventricular groove. Then we have pulmonary artery. Then we have right atrium and right ventricle. Pause it and give the answer. So the correct answer for this question is option B, that is AV groove. Let us see to the explanation. This patient has a biventricular pacemaker, a device that requires 2 or 3 leads. If 3 leads are used, the first 2 are placed in the right atrium and right ventricle. They mean to say like the first one is over here and the second one. Okay, the third lead is used to pace the left ventricle. This is for left ventricle. The first and second lead, right? That is used in right atrium and right ventricle. The third would be used in left ventricle. Right atrial and ventricle. Right atrial and ventricular leads are easy to place as they only need to traverse the left subclavian vein and superior vena cava, right, to reach these cardiac chambers. In contrast, the lead that paces the left ventricle is more difficult to position. The preferred transvenous approach involves passing the left ventricular pacing lead from the right atrium into the coronary sinus, okay, which resides in the AV groove. This is important, that coronary sinus resides in the AV groove on the posterior aspect of the heart. It is then advanced into one of the lateral venous tributaries in order to optimize left ventricular pacing. Why not option A? The interior interventricular sulcus courses toward the apex of the heart on its interior surface, and that would carry interior descending vessels like LED, right? Left interior descending artery. Why not option C? The pulmonary artery lies just to the left of the center on the interior surface of the heart. It courses from the right ventricle toward the aortic arch. This thing is important. Swan-Ganz catheters traverse the pulmonary artery, right? One at option D and E, the right atrium and ventricle are visible on the rightmost section of cardiac silhouette. So, left ventricular leads in biventricular pacemakers course through the coronary sinus, which resides in the AV groove, right, on the posterior aspect of the heart. So, this is on the posterior aspect of the heart, right? So, we have left ventricular coronary sinus, in which we would keep this slit, right? So we have question number 5. A 55-year-old man is brought to the emergency department due to shortness of breath, productive cough, and confusion. His wife mentions that last week he was diagnosed with the flu, and his symptoms have progressively worsened. Temperature is 39.4 degree centigrade. That is 103 degree Fahrenheit. BP is 80 by 50 m of Eg. Pulse is 120 per minute, and respiratory rate is 20 per minute. Pulse oximetry shows 80% on room air. On physical examination, the patient is obtunded and in respiratory distress. He is intubated, given a 2-liter bolus of normal saline, and started on broad spectrum antibiotics after blood cultures are obtained. Okay, a central line is placed to access a structure embryonically derived from the common cardinal veins. This is important. They are talking about this thing. We would focus on this thing, right? This structure is represented by which of the following labels shown in the chest CT scan below. So they are asking about a structure that would be derived from the cardinal veins, common cardinal veins, right? This is important. So let us see to the CAT scan. Okay. So they have mentioned this one over here A, then this one B, then we have C, right? Then we have D, and then we have E. And respectively, they have given options for those. So respectively, they have given option A, B, C, D, and E. So pause it and give the answer. So the correct answer for this question is if we watch to um, if we look to the cardinal common cardinal vein, they would give rise to um, superior vena cava. So over here, this is the superior vena cava, right? And this one is the ascending aorta, right? And this one is the pulmonary trunk, right? And over here they have played a trick. Over here, this one they have represented this with D, but this is not uh, a descending aorta, right? This is esophagus, right? While this one, which they have represented with E, which would look like esophagus, but this is not esophagus. This is descending aorta. So the correct answer is option A. All right. Let us see to the explanation. Okay. So this one is option A. Okay. Okay, good. So as I was saying, the normal chest CAT scan is showing this one over here, superior vena cava, this one, right? And then we have ascending aorta over here. Then this one is a pulmonary trunk, from here till this one. Okay. Um, Let me remove this. Okay. Then we have this one. Uh, yeah, this one is esophagus. Okay, we talked about this, and this one is descending aorta. So this is important, and these black things are main stem bronchi. Okay, so patients with hemodynamic instability or shock often have central lines, right, placed into the central venous system to allow rapid infusion of IV fluids, blood, and vasopressors. The catheter is usually inserted into the neck. If we are inserting that through the neck, that would be through internal jugular vein. This is important. Or if you're inserting that to the chest, that would be subclavian vein. Note this point. And is advanced until the catheter tip enters the superior vena cava. Right. Our main goal is that the superior vena cava is derived from the common cardinal veins. Okay, this is important. And CAT scan imaging of the upper thorax. Okay, the superior vena cava can be identified to the right of the heart, would be located on the right of the heart, right? Okay. Um, Posterolateral to the ascending aorta. Posterolateral to the ascending aorta. Interior to the right pulmonary artery, and just below the level of carina. And one more thing which you shouldn't forget about that. Let me show this for you guys, that we are looking to the patient from their let's say if the patient is in the supine position, right? We are looking to that patient from legs, from leg side of the patient, right? So if let's say let me draw this. If this is the patient, right, these are his legs, right? Okay, so we are looking the patient from here, right? So over here, if you look to that, this region is the right side of the patient and this side is the left side of the patient, right? So as we say, the that the superior vena cava is located on the right side. So as we say, this is the right side of the patient, so this will be located over here, right? And if we look to the descending aorta, that is located on the left side of the patient. Okay, so this thing is important. All veins in the developing embryo ultimately drain into the sinus venosus, which drains into the primitive atrium of the developing heart. In early embryonic development, the body's veins fall into three main groups, that is umbilical, vitelline, and cardinal veins. Right? This is important. The umbilical vein degenerates. The vitelline veins form the portal system, and the cardinal veins form the constituents of that systemic venous circulations. This thing is important. Once again, umbilical vein that would degenerate, right? And vitelline vein that would form portal system, right? And the cardinal vein that would form systemic venous circulation. Okay. So one option is the descending aorta develops from the truncus arteriosus, which also gave rise to the pulmonary trunk, right? So the truncus arteriosus would give rise to ascending aorta with that pulmonary trunk. A portion of the aortic arch develops from the fourth um, branchial, that is pharyngeal arch, right? So the fourth pharyngeal arch pouch that would give rise to aortic arch. We know this, like if we have this aorta, the ascending aorta, this one, then we have this aortic arch, then we have descending aorta. So this one has been derived from fourth pharyngeal arch. Okay. So one other option C, the pulmonary trunk, which is derived from the truncus arteriosus. We talked about this thing, right? Neural grass cell migration helps partition of the truncus arteriosus into the two great arteries, that is aorta and pulmonary artery, by causing fusion interesting at the truncal and pulpal ridges. This process results in a normal spiral relation between the aorta and pulmonary artery. Failure of this process can result in transposition of the great vessels or a tetralogy of failure. This is important. If there is no migration, if there is failure of that migration of the neural grass cell, that would lead to transposition of great vessels. The first one problem, and the second one, it might lead to tetralogy of failure. Right? So why not option D also? Because esophagus is not derived from a common cardinal vein. Okay, then from where? Esophagus is embryologically derived from endodermal foregut. Yeah, in the thoracic cavity, it descends posterior to the trachea, and this is important. Posterior to the trachea, right? And interior to the vertebrae. Yeah, we know this thing, but posterior to the trachea. This is important. The descending aorta is derived from fusion of the embryonic right and left dorsal aortas, right? Descending aorta that is derived from fusion of embryonic, that would be left and right dorsal aortas. In thoracic cavity, it starts left of the vertebral column, right? When it approaches the midline, as it descends toward the diaphragm, right? So what would happen? They mean to say, if let's say, let me draw this. If let's say if this is the vertebral column, right? uh, in thoracic cavity, it starts left of the vertebral column, so they would start over here on the left side, but then it would go toward the midline. Is it going downward toward the diaphragm? Okay, good. So the common cardinal veins of the developing embryo drain directly into the sinus venosus, right? These cardinal veins ultimately give rise to superior vena cava. This is important in other constituents of the systemic venous circulation. Okay, then question number 6. Very easy question. A 35-year-old woman comes to the office due to solid food dysphagia. Okay, for the past several months, the patient has a sensation of food getting stuck in the mid-thorax, but is no pain or reflux. She also has palpitations and dyspnea on exertion. The patient immigrated to the US from India 1 year ago and was treated in her home country for rheumatic heart disease. Okay, this is important. Barium esophagram, okay, demonstrate extrinsic compression on the mid esophagus. Enlargement of which of the following is most likely causing this patient dysphagia? Very easy question. So option A is left atrium. Then we have left ventricle. Then we have pulmonary artery. Then we have right atrium, right ventricle. This is like a very easy. If you have noted, the left atrium is the most posterior part, while the right ventricle, that is the most uh, interior part, right? So two cases are important. So most like in this case, it would cause the left atrium would cause the compression of the esophagus. But note this point also, that the most commonly affected in chest wall injury, is the chamber of the heart, and that is the right ventricle. Okay, but if the now this MCQ will came, we will talk about that. In second MCQ is that if the injury, let's say if someone falls or something, his if someone falls from the roof, okay, or if there is some shattering to the chest of that person, in the fifth intercostal space, with that at the midclavicular line. Let me repeat this thing. In the fifth intercostal space, at the midclavicular line, so that would most commonly affect the left ventricle. Now these are two scenarios which would came in the upcoming MCQs. We will talk about that. So the correct answer over here is option A. Okay, let us see to the explanation. So as I mentioned, that right ventricle is the most interior portion, right? Then we have right atria. Okay, then we have left atria, and with that left ventricle. So left area is the most posterior portion. Okay, so over here if we look at this point, this is esophagus, right? And then we have aorta, right, which is posterior to that. So this patient with a history of rheumatic heart disease, right, he's likely developed mitral stenosis or regurgitation. That can cause mitral stenosis or regurgitation. This is one. For example, palpitations and exertional dyspnea leading to left atrial enlargement. Okay, that would compress. Okay, so extrinsic compression of the esophagus, for example, solid food dysphagia. So the posterior surface of the heart, is mostly formed by the left atrium. This is important, as I talked about this, which lies directly over the esophagus. Okay, longitude. Okay, sorry, long-standing mitral stenosis or regurgitation can lead to progressive left atrial enlargement, as I talked about this, further displacing the left atrium posteriorly and causing external compression of the mid-esophagus with dysphagia. That would be called as cardiovascular dysphagia. Okay, on rare occasions, left atrial enlargement can also cause compression of the left recurrent laryngeal nerve, leading to voice hoarseness, warts, and chronic cough. And this voice hoarseness, because of the left recurrent laryngeal nerve, that would be called Ortner syndrome. This is important. So why not option B? The left ventricle makes up the most of the left surface of the heart. So that would form left surface of the heart, right? Which abuts the left lung. The pulmonary artery emerges from the right ventricle and branches into the right and left pulmonary arteries below the aortic arch. Okay. Why not option D and E? Because the interior, that is sternocostal surface of the heart, is mostly formed by the right atrium. We talked about this superiorly, in right ventricle inferiorly. Blood from the coronary sinus and inferior and superior vena cava drain into the right atrium, which then drains blood into the right ventricle through the tricuspid valve. Okay, simple. So the cardiovascular dysphagia can result from external compression of the esophagus by dilated and posteriorly displaced left atrium in patients with rheumatic heart disease and mitral stenosis and regurgitation. This thing is important. If there is mitral stenosis or if there is mitral stenosis and regurgitation, that would lead to compression of the esophagus. Now this question is more easier than that one, than the previous one. Okay, so we have a 35-year-old previously healthy male evaluated for several episodes of syncope in the first 6 weeks. Physical examination is unremarkable. Echocardiogram shows no structural heart defect. Okay, in electrophysiologic studies performed during which catheters are passed into the patient's right and left atrium to record atrial electric potentials. Okay, cardiac uh, monitor currently shows normal sinus rhythm. Okay, which of the following most likely earliest site of electric activation? So they are asking about earliest site of electric activation. That is, SA node. So they are asking about the location. Let us see. So option A is a junction of the left atrium and the atrial appendages. Then we have option B, left atrium near the opening of the pulmonary veins. Then we have option C, right atrium near the opening of the inferior vena cava. Then right atrium near the opening of the superior vena cava. Then we have right atrium near the septal cusp of the tricuspid valve. Pause it and give the answer. So the correct answer for this question is right atrium near the opening of the superior vena cava. Simple question. Pause it. You must have paused that question. Okay, so the correct answer for this question is option D. Okay, now let us see to the explanation. The cardiac conduction system consists of SA node, right, then AV node, and a bundle of His, right, left bundle branches, Purkinje system, which directly activates the ventricular myocardium. They're talking about this thing, right? In patients with normal sinus rhythm, is in this patient, the AC node acts is the dominant pacemaker site uh, and is the site of earliest electrical activation. The AC node is compact subepicardial structure that consists of specialized pacemaker cells located at the junction of the right atrium and superior vena cava. So final option A and B. The AC node is located uh, in the right, okay, not the left atrium. This is important. The area around the opening of the pulmonary veins in the left atrium is frequently involved in the pathogenesis of AFib, afibrillation. This is important. You shouldn't miss this. Area around the opening of the pulmonary veins, right? In the left atrium. For example, let me draw this for you guys. So if let's say if these pulmonary veins are coming over here in the left atrium, this area is frequently involved in the pathogenesis of AFib. This is important. Okay, why not option C and E? Because the junction of the right atrium and inferior vena cava is not the major site of electrical activity. Yeah, we know about this thing. Okay, the AV node is located in the right atrium near the septal cusp of tricuspid valve. They're talking about AV node. Okay, so the sinoatrial node consists of specialized pacemaker cells located at the junction of right atria and superior vena cava, site of earliest electrical activation. This is important in patient with sinus rhythm. Okay, now question number 8 and 9, they are connected with each other. Okay, so the following vignette applies to the next two items. Okay, let us see. A 52-year-old man is brought to the emergency department, okay, for evaluation of fever, chills, malaise. Cardiopulmonary examination reveals a new hollow systolic heart murmur, okay, that radiates toward the axilla, okay. Blood culture are obtained and the patient undergoes transesophageal echocardiography. The ultrasound probe is placed in the mid esophagus facing anteriorly, and the cardiac chambers are interrogated, okay. Now again, this is the same question which we earlier talked about that. So Item 1 of 2, which of the following chamber is closest to the probe? Simple question. So option A, left atrium, then we have left ventricle, and right area, right ventricle. So the correct answer is what? Pause it and give the answer. Okay, so the correct answer for this question is left area. Why? We would talk about this thing now. Okay. So this patient's presentation suggests acute endocarditis with confirmation pending the results of the blood cultures in cardiac imaging. Transesophageal echocardiography, that is TEE, uses ultrasound waves generated from within the esophagus, right? To produce clear images of the neighboring cardiac structures. The left atrium makes up the majority of the heart's posterior surface, with esophagus passing immediately posterior to the heart. Therefore, the esophagus lies within close proximity to the left atrium. This is a simple question, right? So this allows the left atrium, aerial septum, and mitral wall to be particularly well visualized on transesophageal echocardiography. So due to its proximity conditions that result in left atrial enlargement, mitral stenosis or regurgitation can cause dysphagia through external compression of the esophagus. We talked about this case in the previous scenario. Okay, so why not option B? Let us see to the explanation. Because the left ventricle forms the majority of the inferior, the diaphragmatic surface of the heart. Okay, and left part of the heart and the frontal chest X-ray. So we are not related in this case to the esophagus. The right atrium, along with superior vena cava, forms the right lateral cardiac border on the frontal chest X-ray. Why not option D? Because the right ventricle forms the interior, that is sternal surface of the heart, and the majority of its inferior border on the frontal chest X-ray. So the left atrium forms the majority of the posterior surface of the heart. This is important, posterior surface, right? And resides adjacent into the esophagus. Yeah, enlargement of the left atrium can compress the esophagus, and that would cause dysphagia. Yeah, simple. Now this is the item two of two. This is also related to that previous scenario. So what they are saying, in the same mid-esophageal position, the probe is rotated so that it now faces posteriorly. Which of the following structures will be best visualized with the probe's new orientation? Very simple question, right? Like they are asking, they are saying, just like, if let's say, let me draw this thing for you guys. First, let me say the options: descending aorta, pulmonary artery, pulmonary veins, superior vena cava, tricuspid valve. Pause it and give the answer. So the correct answer for this question is this one, option A, descending aorta. Why? Let me draw this for you guys. For example, this is the heart, right? So let's say if this is the left atrium, over here, let's say a drawing is made, but it's okay. Like, you're good guys. You can learn from this. Okay, so here would be esophagus, right? And posterior to that, we have descending aorta. So the correct answer for this question is descending aorta. Okay, good. Now let us see the explanation. So like over here we can see we have transesophageal probe, that is through the esophagus. Okay, so in the front, like if we look at the front, and we have left atrium, and posterior to that we have descending aorta, right? Okay, then with that we have pulmonary trunk and pulmonary wall, aortic wall, right? And we have right ventricle and a ventricular septum. Okay, we have left ventricle and we have mitral wall. Okay, so the aorta has four major divisions. Okay, the ascending aorta, aortic arch, descending thoracic aorta, and abdominal aorta. Okay, the ascending aorta lies posterior and to the right of the main pulmonary artery. Ascending aorta, right, that lies posterior, okay, and to the right of the main pulmonary artery. This is important. The aortic arch travels above the right pulmonary artery. So that is about the if we look to this thing, right? So they're talking about this thing. This is the arch, but this is the pulmonary artery. So that is about the pulmonary trunk, right? Pulmonary artery. Like, note this point: ascending aorta is lies posterior. Let me show this for you guys. To the end, to the right of the main pulmonary artery. If we look to that like if let's say yeah, we have like this one is a pulmonary artery, then this one is the ascending aorta, which is posterior and on the right side of that pulmonary artery. So they are talking about that thing, right? So we were talking about that aortic arch travels above the right pulmonary artery. We talked about this, and also about the left bronchus. If we look to this thing, like this one, let me draw this. This is left bronchus. So above left bronchus, also okay. And the brachiocephalic, left common carotid, and left subclavian arteries in that order originates from the superior aspect. They mean to say like this one over here is the brachiocephalic, right? And this one is left common carotid artery, and with that left subclavian artery, right? Okay. The descending thoracic aorta travels down the interior surface of the vertebral column, becoming the abdominal aorta as it crosses the diaphragm. Right? This is important. When it crosses the diaphragm, then it would become abdominal aorta. As it descends, the aorta moves from the left side of the vertebral column toward the midline and the level of cardiac chambers. The descending aorta lies posterior to the esophagus. We talked about this thing. And the left atrium. This permits clear visualization of the descending aorta during transesophageal echocardiography, allowing for the detection of abnormalities such as dissection and aneurysm. Right? The other answer choice is describe structures located interior to the esophagus. So all these structures are interior to the esophagus, right? For example, the main pulmonary artery ascends interiorly into the left of the ascending aorta, right? As we talked about this thing, like the ascending aorta is posterior to the main pulmonary artery. So opposite to that, the main pulmonary artery is interior to the ascending aorta. Simple thing, and is directed toward the left shoulder, right? Okay. So they mean to say like this would go to the left side, right? Yeah. After the pulmonary artery bifurcates, the right pulmonary artery travels horizontally under the aortic arch posterior to the superior vena cava. Now this thing is important, that this right pulmonary artery is posterior to the superior vena cava. Let us see to this. Okay, like we can see over here that let's say if we have this if it gives a right pulmonary artery, that would be if let's say if over here it is the superior vena cava, so it would be uh, posterior to that superior vena cava, right? For example, let's say if this is the superior vena cava, right? Let me draw this. Let's say this is the heart. Okay, so the pulmonary artery would be behind this superior vena cava. Okay, and the left pulmonary artery courses superiorly over the left main bronchus, right? Okay, now why not option C? The superior and inferior pulmonary veins uh, arise bilaterally from each lung and enter left atrium. The proximal 2 to 3 centimeter of the pulmonary veins contain cardiac muscle within the media and function like sphincters during atrial systole. So they act as sphincters. This is important. Why not option D? The superior vena cava is formed behind the right first costal cartilage by the merger of the right and left brachiocephalic veins. So they would combine. They mean to say the right and left brachiocephalic veins would combine. They would drain into the superior vena cava. It returns blood from the head, neck, and upper extremities. This is important. Head, neck, upper extremities to the right atrium of the heart. Mediastinal neoplasms can compress the superior vena cava and result in superior vena cava syndrome. This is important. Note this point. Whenever there is mediastinal neoplasm that could compress superior vena cava, okay, then that would result in superior vena cava syndrome. The tricuspid wall is located between the right atria and right ventricle and is composed of three wall leaflets: annulus, supporting choroid tendineae, and papillary muscles, commonly infected, that is endocarditis in IV drug users. So the descending thoracic aorta lies posterior to the esophagus, okay, and the left atrium. This position permits clear visualization of the descending aorta by transesophageal echocardiography, allowing for the detection of abnormalities such as dissection and aneurysms. Yeah. Okay, now let us see the question number 10. Question number 10 is easy or hard? Let us see. Okay, so a 66-year-old man comes to the hospital due to sudden onset chest pain and dysphagia. The patient has a history of asthma and gastroesophageal reflux disease, but says his current symptoms feel different than what he usually experiences. In ECG is consistent with ST elevation MI, that is myocardial infarction, and in emergent cardiac catheterization is performed. Evaluation of the left and right coronary arteries reveals left dominant circulation. Yeah, this is important. A stenotic region is identified in one of the coronary vessels just before the origin of the artery supplying the AV node, that is atrioventricular node. Which of the following arteries most likely affected? Okay, uh, the options are interior interventricular artery, left circumflex artery, left diagonal artery, right coronary artery, right marginal artery. So what do you think? Uh, Pause it and give the answer. So is in this case, in my opinion, this is left dominant. So this would be the branch of what do you think? This would be the branch of left circumflex artery. Let us see. Yeah, it's right. It's the because it is a left dominant. So let us see the explanation. As we know that the coronary dominance is determined by the coronary artery that supplies blood to the posterior descending artery PDA or posterior interventricular artery. The PDA originates from one of the following, that is right coronary artery in approximately 70 to 80% of the population, that is right dominant. Left circumflex artery, that would give rise to PDA in approximately 5 to 10%, right? That is left dominant. Okay, and then if there is the branches to the PDA from both, that is right coronary artery, and with that left circumflex artery, that is found in 10 to 20%. That would be considered as codominant, right? Now the AV, that is atrioventricular nodal artery, most often arises from the dominant coronary artery. This is important. This patient has a left coronary artery circulation, therefore his atherosclerotic lesion is most likely in the left circumflex artery. Involvement of the AV nodal artery during myocardial infarction can cause varying degrees of the AV block. Yeah. So one option A, let us see to the explanation. Left anterior descending artery, that is called LAD, travels in the interior interventricular groove and supplies the anterior part of the septum and anterior wall of the left ventricle, but it doesn't supply the AV node. Remember this. And usually like from 70 to 80%, we have the supply to posterior descending arteries from right coronary artery. So that case is related to that. A right coronary artery in that case would supply the AV node, but now in this case it is left is in this case it is left dominant. So this couldn't be the answer. So why not with that, why not option D? Sorry, why not option C? The diagonal arteries. Uh, Let me draw this. Okay. The diagonal arteries arise from the LAD and supply the anterolateral wall of the left ventricle. Once again, it is not the correct answer. Yeah, why not option D? So I was talking that the why not option E, like right marginal arteries arise from the right coronary artery that would supply blood to the free wall of the right ventricle. So the coronary dominance is determined by the coronary artery supplying the posterior descending artery, that is PDA. The posterior descending artery originates from the right coronary artery in approximately 70 to 80% of the patient, which are right dominant. But both the right coronary and left circumflex artery in 10 to 20%, which are co-dominant. In the left circumflex artery in 5 to 10%, which are left dominant. The dominant coronary artery supplies blood to the AV node via the AV nodal artery. So for today, I think it's enough. We did 10 questions in 1 hour. I think it's a good and a quick speed.